like to thank Dr. Stain for inviting me to talk here today. It's the first surgical meeting I've been to in about 7 years. I came to this in a very roundabout way, and when he first asked me to come speak, I said, well, why do you want me? I'm not a professor. I have no academic background. And he said, you know, you bring a whole different perspective to this. And we've had some new innovative programs that we're doing in Albany, and the plan itself has developed a history of being an innovator in medical home, in healthcare in general, and recently we've started getting some national attention. So he said, why don't you come here and speak a little bit about yourself, your company, and some of the stuff we've done. So here I am. For my disclosure, it's simple. I have nothing to disclose. A little bit about me and my background. Private practice cardiac surgeon for 20 years in a single practice in a single location. 10 of those years were as a managing partner, which really is where I started getting some interest in management and healthcare policy. In 2009, I retired from active practice, and as Stephen said, I obtained a master's degree in public health and board certification in preventive medicine. In 2011, as part of that residency, I needed some public health background, and the rotations that were available really weren't anything I was interested in. So I got involved through a variety of means to become Vice President of Medical Affairs and Chief Medical Officer of CDPHP Medical Center, which is a hospital in Plattsburgh, New York. It's about a 300-bed hospital, has about a $300 million operating budget. During that time, I also got involved with the Adirondack Health Institute, and there's currently still an active participant in the Institute, as well as the Medicare Adirondack Medical Home Pilot. And currently, I'm Vice President of Medical Affairs and Senior Medical Director at CDPHP. When CDPHP reached out to me to come down and back home and start working on some of these projects, I was looking at the commercials, and the closing line by the CEO is, we're more than an insurance company, we're really a health plan. So in discussing with him, I said, you know, if this is marketing nonsense, I'm not interested, you've got the wrong guy. And he said, you know, actually, he said, I'm used to taking care of patients one at a time, and now I can take care of 450,000 at a time. He said, I think you'd really like it, and I think you'd do very well at it. So I agreed to join the company. The company itself is physician-founded and governed. It was established in 1984, serves 24 counties in upstate New York. Currently, we're at just over 450,000 members. We have just over 1,000 employees. One of the things that I like about the company, and very few people even locally are aware of, we are truly a non-for-profit. Our board structure is unique in that by charter, there have to be 8 practicing physicians on the board and 7 members of the community. And our committee structure has to be made up of actively practicing physicians. That's our 24-county core region, but on our commercial side, we're also tied to the Magna Care network. So we do have members who do go to other cities and outside the area for care. When I got there, I really was concerned that they really practice what they preached. And the awards here, to summarize that slide, they generally do as a company. Recently, in 2013 to 14 by NCQA, we've ranked #1 in New York State across all lines of business. We're in the top 25 plans in the country. And on the Medicare Choice stars, we're 4.5 out of 5 stars. This slide just serves to show you that we really are truly a non-for-profit. We actually target in our budgeting process a surplus operating income of about 2%, and the majority of the premium dollar goes to physician and hospital. We do have our ancillaries for DME, and our administrative cost is 12%, but also includes a lot of things we do in the community. We are a triple aim company, and we have embraced the health value strategy. We belong to the Alliance of Community Health Plans, and we really are truly involved in enhancing the long-term viability of the regional providers, and that's one of the reasons I'm here today and some of these programs we've done. Again, we've used technology to try to really integrate the health value strategy between members and providers, and we really use the employers and brokers to deliver our message. And our primary goal is to increase the quality of care for our members. Recently, when I got to the program, I was asked, you know, if you see anything here that doesn't make sense or you think is stupid, just bring it up and let us know about it, and let's try to change some of our internal processes. So the evaluation of new technology, again, in cardiac surgery, I was involved in minimally invasive surgery and bringing it to the region with my partner. We were involved in the early days of AFib surgery and mini-maze procedures, and I saw the frustrations of the surgeons trying to bring this new technology forward. So the current policy that existed when I got there is it's usually a systematic review and a timely review of evolving medical and behavioral health technologies. Medical and behavioral health services that are unproven for safety and/or efficacy are not generally considered by coverage. And CDPHP, up to this point, was utilizing the following criteria to reach their decisions. First, the technology must have final approval from the governmental regulatory bodies. Secondly, the scientific evidence must permit conclusions concerning the effect on health outcomes. Third, the technology must improve the net health outcome. The technology must be as beneficial as any established alternative, and the technology must not be cosmetic in nature and is required for reasons other than for convenience. The current process, research is initially performed by a medical policy analyst. A lot of the resources that have been described today and a lot of the processes have already taken place by the time it comes to our desks. In general, consultants were used when additional expertise was needed regarding new and emerging technology, and then it was reviewed by the technology assessment team. If approved, the technology is then presented to the Policy Committee, Utilization Management Committee, and/or Pharmacy and Therapeutics. The outcomes of a technology assessment team decision may include the development of a new policy, the revision to an existing policy, or to address future covered benefit or to address non-coverage of a reviewed new technology. This is the flow diagram that was used. It's basically what I just described. What concerned me in this when I was looking at it is that medical director involvement and consultant involvement were optional. So a lot of these decisions were being made and presented to the committees without the practicing physician involved in the process, and that I found was disturbing. So I went to them and I said, you know, we really got to change the way we do things, and our policies are written by people who are either not practicing in that specialty. The research is done and reviewed by and prepared for presentation to the medical directors, if they're involved at all, by non-practicing physicians in that specialty. It just doesn't make sense. So they really gave me the latitude to change it, and after some discussion with Dr. Stain and actually one of his younger surgeons who was involved in trying to bring some new technology forward, we actually changed our process and were fairly successful. So the first 3 steps of the process stay basically the same. Since I've come into my new position, once the research is done, it's mandatory that the technology assessment is reviewed by all medical directors. So I bring them in a room, we review it, we discuss it. People can bring forth at that time their concerns. And then we actually bring the sponsoring physician to the plan to present his case or her case to the medical directors at that time. What I like about this in particular makes our plan a little different. It's one of the rare opportunities where the leadership team from the plan and the CEO can be present and actually make a decision. Then we come up with a decision. We create a resource coordination policy. We create the payment policy, and then we bring the recommendation to the committees. If it goes through the committee process and is finally approved, then we put it into the pre-authorization process, and then we review the policy on a yearly basis. And in general, for new technology, there's usually some type of registry or database that they're involved in. We review the results and then decide whether we're going to continue with the policy or not. We've had 3 processes we've used so far: the Apollo overstitch, lariat procedure, and TAVR. We brought them through the new process. I got to tell you, the physicians have been very respectful of the process. There's been absolutely no abuse, and it's been a very smooth process. Currently, we're involved with Prometheus Labs and some of their proprietary testing. Dr. Singh, one of Dr. Stain's surgeons, just brought links forward to us, and we've just been asked to evaluate the smart pill. You may ask, why do you bother doing this? And last night at dinner, it was interesting that a lot of people really didn't know, and I didn't know when I was in practice what actually happened. So I got to tell you, the denial process is very expensive and is very cumbersome, and we're trying to shake some of the waste out of the system, and a more efficient process is definitely one way to do that. My complaint was that in some of these technologies, because of the appeals process that's involved and getting new technology approved, there really is some very good technology, and you really delay that technology being rolled out to patients. I think the whole process that you have to go through to bring it through is an undue burden on physicians, and in certain situations, there's the potential for unfair competition. And that's all I have to say.